Thank you all for joining us this afternoon. We're looking forward to an exciting presentation brought to us by the SupplyCopia team. Looking forward to 6 months to savings that matter. I'm going to turn it over to Cheryl Fleury and have her kick us off. Cheryl?
Thanks, Diana. It's great to see everyone today. Thank you so much for joining us. I'm Cheryl Fleury. I'm a marketing consultant that works together with the SupplyCopia team, and it's my pleasure and honor to get to see all of you today as we talk through this, what we hope will be a very interactive discussion about getting to savings that matter and how you can make that a shorter path than what you might have experienced previously. We have a team of experts, and I'd like to ask the team to go around and just give a quick 30-second introduction to themselves. And then, Ashok, when we're through that, I'll call on you and ask you to introduce SupplyCopia. Zulfi, can we start with you?
Sure, Cheryl. Thank you. So I am Zulfiqar Lakhani. My friends call me Zulfi, and I lead the clinical and the data management teams here at SupplyCopia. Nice to meet you all.
Thanks, Zulfi. Dale, let me go to you. Would you introduce yourself and your role in this particular discussion?
Yeah, thanks, Cheryl. My name's Dale Locklear. I'm retired. I retired from McLeod Health after 17 years there. Most of which I served as a senior vice president for planning and facilities, and had the privilege of working with a really talented supply chain team there that was just a lot of gifted people. So it's a pleasure to be back and to engage with you all in this work with SupplyCopia.
And we're so fortunate to have Dale join this discussion. He was part of a project that we'll be talking about as we go through today's conversation. And Ashok, let me go to you and ask you if you would please introduce yourself to the group.
Thanks, Cheryl, and thank you everybody for making the time to join us today. My name is Ashok Muttin. I'm the founder and the CEO of SupplyCopia. If you don't like something in what we are showing to you today, I am the person responsible for it.
Thanks, Ashok. And Rishi, can we go to you and ask you to do a quick intro to the group?
Sure, Cheryl. Hi, everyone. I'm Rishi. I lead the product management at SupplyCopia. So all the product analytics and all the activities here. Thanks. Nice to meet everyone.
Thanks, Rishi. And we will go through this group as we go through the discussion. I want to ask Ashok if he would give us a really brief overview of SupplyCopia just to tee up what we'll be talking about today.
Okay, thanks a lot, Cheryl. Cheryl has told me I can't speak more than 2 minutes, so I'll try to do that. So none of these challenges are new to any one of you, but I want to kind of reiterate from the perspective of how at SupplyCopia we solve for each one of these challenges. Data is a known problem, and whether that data is connected to the product item master, pricing, contract data, procedure data, utilization, however you kind of think about it, we look at that as a foundation, and we'll talk a little bit more about it during the presentation. But that's a challenge that we believe we have conquered. The second one is with reference to the ERP reliance. Whether that ERP that you are implemented is the latest ERP or you have one of the older versions of the ERPs, whether it's on the cloud or behind the firewalls, there is still a significant amount of challenges that you get there because of the interoperability and other issues. We believe we have solved for that here in SupplyCopia. The third one is it refers to those of you who are running both acute care as well as non-acute care. They tend to be run as two different organizations, and hence you're not able to leverage the efficiencies of scale and so on and so forth. That's another challenge that we address through our platform. And the last one is more to do with visibility into how your operation is being run, whether it's the cost of the procedures, whether it's the cost of the products, whether it's your indirect costs that are playing a role into it, what constitutes your entire spend. These are kind of the four buckets that we generally address through our platform. And we believe we have created a unique solution for each one of these challenges. And you will tell us we are on the right track or not. So keeping these challenges in mind, we architected the platform in such a way that it seamlessly integrates both the providers and the suppliers. And then it's entirely up to every organization to decide what is it that they want to do, what are their key objectives, and how do you meet those key objectives through either one of the modules in the platform or a combination of multiple of these modules. So looking at the nature of this discussion, I will just stick to the provider part of it because that's where you all live in. What we have created, going back to those 4 challenges that I mentioned earlier, in order to address these challenges, what we have created is a unique platform. This unique platform consists of virtual item master. In our world, we call it as a global product database. And then there is the whole requisition management associated with it. And on the application side, we have a preference card management software. We have a capacity planning software. And then to support the strategic sourcing people, we have the RFP and the contract management software. Then on the analysis side, everything that we do kind of ends up in analyzing the data or supporting the applications. So we have created what we call as an industry leading CQO software, which brings your cost, quality, outcome, and will show some of that to you. And then we analyze the spend data. What I mean by spend is that we pretty much analyze every spend that there is. One is connected with the procedures and so on and so forth that goes into the CQO. And then the spend analysis is all the other things that you may be purchasing, including all your purchase services and so on and so forth. So each one of these modules is integrated into each other, and it also seamlessly integrates with your EMR, EHR systems on the one hand, and then your ERP systems on the other hand, so that we kind of sit between those two worlds and seamlessly integrate the data from all of those systems so that any kind of a recommendation, any kind of an insight that is generated is not done in a vacuum, but taking into consideration all of these data points.
So what we'd like to do, everyone, throughout this discussion, now that you have a bit of a foundation, you've heard from the group, we'd like to create an opportunity for this to be as interactive as possible. Diana and I will both be playing timekeeper, and so we want to make sure we keep us on schedule and that we have an opportunity to get through the discussion today. We'd really like to hear from you throughout. And so if you have questions, if you have things you'd like to throw into the discussion, please come off of mute and feel free to ask your question or use the chat. And right now, I'd like you to use the chat, if you would, please, and tell us what's your biggest supply chain challenge today. And these are areas that we're going to talk about in more detail as we go through the conversation. But we felt like, based on what we've heard, they usually fall into 4 buckets. Is it about data maintenance and management? Is your biggest constraint time and resources? Are there financial barriers that you're dealing with in your supply chain, budget costs, reimbursements, revenue? Or is it really being able to get to reporting and analytics? So if you would please use the chat and just let us know really quickly which of those is your most significant challenge. Okay, we have a financial. Others? We have one for time and resources. We'll definitely be covering these topics. We'll keep going. And so these are 4 buckets. Oh, and an A&D. So it sounds like it's good that we're prepared to talk about all of these. All 4 of these issues are the areas where you're most likely to be looking for ways to adjust your processes, maybe get some help refocusing your team and thinking about some of the ways that you might be able to shift your resources into areas of greater productivity. And so with that, as we dig into this area, Dale, I'd love to go to you and get the conversation started. We hear a lot about how burdened and how stretched supply chain teams are in health systems and in hospitals today. Can you talk about that for us? You have all those years of experience at McLeod. What are those big challenges and what are those issues like?
Sure thing. Cheryl, things have, in my perception, seem to have worsened for people who are still working in supply chain. They're stretched even thinner than they ever were. They're overworked more. They're burned out. They're dealing with log jams of routine transactional work that is at times unproductive. And I think just looking at some of the responses, I noticed Alan's, you guys have to be feeling real pressured by the difficult circumstances that are beyond your control. You're faced with declining revenues, and that has created constraints and significant cuts in budgets. And some of you, if not all of you, are dealing with high turnover among your staff and those increased workloads. And then you've got to train new people, some who are not even experienced in healthcare, while you're dealing with all this other pressure. And so working with these kind of compressed, overloaded schedules, in addition to those greater demands for quick, reliable data to get opportunities to find rapid, meaningful results that reduce cost or improve savings or achieve savings, is really difficult. So you're capable of doing so much more than you really are if you just had the time to do it. And it's helpful to rethink about how we frame things from a cost initiative, I think, when we're working on those projects. And what I mean by that is we all have a unique perspective in how we view and understand information when it's presented to us. And one of the challenges, how do you help others to see and understand that information in a way that's more than just throwing data in front of them and expecting them to draw the same conclusions that we might have? So how we frame our presentations of the data to others often makes us want to step back and reposition that information so it's easy for a consumer to digest it and understand it. Another way of thinking about this is we can effectively present data or information to our audiences in a way that can be quickly grasped what we're trying to convey in less time and with less effort. So that means we have time saved that we can use for something else. Instead of just dumping data in front of people, I think our focus has to be on what is the reaction we want to get from them and how do we need to build a story that helps to relate our need to them for the project, and then how we build that story into a way that helps teams come together and work collaboratively together.
Thanks, Dale. You started to touch on data, and I want to ask Ashok, would you dig into data a little bit further for us? And I can go on to the next slide if that's
Sure.
better. If we think about data as being at the center of everything we do, and one of the foundational challenges that we're dealing with, let's look at what that data issue is and how we can overcome it.
Yeah, thanks, Cheryl. Data is the center of everything. It doesn't matter whether you are a single hospital system or you are a large IDN. Data is the core to everything that we look at, and that becomes the foundation. So the approach that we have taken in SupplyCopia is that all of this heavy lifting that is required is something that you should not be worried about. You should be worried more about what insights do I get from this data? What are some of the recommendations that the system is helping me? So what we have done is created what we call as a data lake. And this representation is a very, very simplified version of what goes on behind the back here. So we've created this data lake in order to support every one of our customers. And this data lake, I almost say, sometimes at the cost of sounding redundant, is it's almost like an Airbnb of your CQO, if you will. Everything has been kind of laid out. You have to bring your clothes and your toothbrush. And in this case, that happens to be your data. So we understand that every organization is going to be at a different maturity level. And hence, we have architected this data lake in a way that we basically take all of the data, whether it is the item master data, whether it's the cost data, whether it's the utilization data, patient demographics, and all of that sort of a stuff. We have created a very sophisticated data pipe that takes all of this data into the system. And then there is a warehouse that it goes through. And there is various mapping and all of that sort of a stuff that happens in the back end, which you don't need to necessarily worry about. At the end of the day, what you are looking at is this particular piece where the insights from all of your operations are analyzed in the back end and shown to you as a recommendation. hey, here is where your case costs are varying by X percentage. Here is where your utilization is going haywire. Here is where your billing to the reimbursement is going crazy. Here is how that scanning errors may be happening. So it takes into consideration there is a humongous amount of intelligence that is being built into it, and it is a very structured, sophisticated platform, but it's also flexible enough to take various maturities of the data. So Jack was actually asking me when utilization, we basically take into consideration all of the material usage in a particular procedure, whether it's an implant, whether it's the consumable, however that is, and then we bring it all into the data lake. There are machine learning algorithms that are constantly looking at this data and coming up with very useful insights. It has the standard levers, like you look at price parity, you look at demand, you look at functional equivalent products, you look at contract compliance, you look at all those. But the software goes much beyond that and actually does a correlation between what is my procedure, my cost, my outcome. With the patient outcomes being the center of the universe, we have built this model that is ready to go to the market, and all it requires is your data, and that data could come in multiple formats, multiple structured and unstructured ways. The data could have a lower maturity. We have built that flexibility to suck that data, and at the end of the day, provide you very, very concrete recommendations on where the cost savings are.
Perfect. Thanks, Ashok. I want to keep us moving along and make sure that we have time to get to the demo. So, Dale, I'm going to tie together Ashok's comments with regard to data. And I know that you had some insights with regard to how important the item master is and how within the control of a health system managing the item master is. Can you talk about the item master and then segue us into the CQO project?
Yeah, absolutely. The item master for all of us is our data lake. It's the core of all the work we do, and benchmarks actually get their origin from that data lake. I like to think about it like this. If I were to remember in 1969 when NASA launched its first moon landing, if they'd have been off by 1 degree in the data that they calculated, they would have missed the moon by over 4,000 miles. That's twice the diameter of the moon. And so if we eliminate waste and reduce waste by using our time more effectively, and that is a result of the item master and all the data that we have being accurate the first time it is right, then it frees up a tremendous amount of time for us to do productive work. And, there's always a saying, if you don't have time to do it right the first time, when will you ever have time to get it right? So focusing on the accuracy of the information is important for a number of reasons. I noticed when I just checked the list of who all is on the call, one of the people here is BJ McCluskey, and BJ is now an associate vice president at McLeod, and he was very active in this project when McLeod undertook it. It was at the time, if I remember all the details correctly, and I'm getting old and I'm retired, but if I remember it right, we had 5 vendors that we spread our total joint implant out over. And BJ, you feel free to correct me, please, if I should misstate something here. But we had 5 vendors across 6 hospitals and ambulatory surgery center as well. And the challenge for us was that the surgeons honestly believed that to give their patients, and this is a story everybody on here is going to be familiar with, to give their patients the best possible care and achieve the best possible outcomes, they were compelled to use their particular brand of implant. And I think it's important to recognize that this wasn't because they were flippant about or just didn't care about the cost of the organization. They honestly believed they were doing the right thing and contributing in the most positive way possible to the organization's financial well-being, and that each one of them believed that their outcomes were better than their peers, and they were doing it at as profitable or more profitable than their peers were. I think in a lot of cases, they didn't understand the difference in revenue, reimbursement, contribution margin, and so on. But nonetheless, that was what they believed, and that was their truth. And when we put data in front of people, it's clearly there's just a lot of noise there. And by noise, I mean confusion. And it's important to be able to sort out what data is meaningful and useful and discard the things that are not. And by that, I mean it is important to easily and quickly identify data that helps us build a compelling story. And I'm using that analogy of a story because that's really what we're doing. We're really trying to convey to people our story and to move them into a position that they agree with us and see it the way we see it. Even though we're looking at the same data, we don't always digest it the same way, but we want to get to the best and most beneficial results possible. So I think the other thing that's important about this is that we're paying too much for something, but we don't quite understand or can't quite put our finger on what's the best way to get to the best results. So, we go through a lot of if then and what if scenarios in data presentation. And in McLeod's case, there was a clear opportunity to reduce spend on total joint by consolidating the number of vendors. That was obvious. What was more challenging was to identify the combination of vendors that would result in the highest and best rebates and the combination of vendors that would get to the best tier structure and ultimately the greatest cost reduction. So you can see that's a really quite a different challenge. And so it was important to understand the best path to greatest savings and then build a story that was compelling enough that the surgeons were willing to align themselves with where supply chain was and join in that difficult work to do what needed to be done. So where I thought SupplyCopia did such a magnificent job was in helping us to bridge all of those problems and to be able to reduce the data to sensible talking points that created a compelling story that the physicians and supply chain were able to enter into a discussion about cost. And in reality, much of that information was probably already given to those surgeons in bits and pieces. But one thing's for sure, the data was never used in an informative way that created a compelling story that either they could understand or were willing to understand, let alone believe. So two driving questions that I would boil it all down to is, what are the selection of vendors in combination, and what combination that would result in the greatest opportunity to reduce cost? And what story had to be told and how would it be told to align those surgeons with the supply chain thought that what supply chain already knew or already thought it knew anyway. In other words, SupplyCopia helped McLeod make sense of all that data. And I like to think of SupplyCopia as a real gifted storyteller more than an analytics company, because SupplyCopia's team was able to take the bits and pieces of disassociated data and bring it together into a compelling story that was believable and it was transparent. So to do that for McLeod, the SupplyCopia team had to identify and align supply costs by surgeon, by patient, by procedure, and then align all that with revenue, reimbursement, contribution margins. And they had to do that by connecting the patient outcomes and readmission data through a third-party provider, because McLeod didn't maintain all that information in-house. So putting all that together, SupplyCopia helped author a compelling enough story that kind of set that platform on fire and led the surgeons to feel compelled to engage in the work. And, I would push back to Ashok here and say, Ashok, your team was so successful at doing that at McLeod. Is that something, we had a particular third-party vendor managing our data for patient outcomes and so on. Is that something you can do for everybody else, or is that just a one-off because it happened to be the provider we used?
The data lake that's been built in, it not only takes into consideration all of your own enterprise data, and then it can take also any kind of a third-party data that you may have, whether that data is coming from the benchmarks or whether that data is coming from any publicly available sources like the CMS, you may be wanting to bring that outcome benchmarking data from other sources. Now, as far as the platform itself is concerned, you can take it and apply it to a small one hospital system, or you could take and apply it to a very large and complicated IDN, right? And it's the data pipes and things like that are all reusable. So it's not a customized solution. No, what it is that the data flow and everything has been established. What is customized and what is applicable to every health system is their own insights.
Ashok, would you tee up the process that was used so that we can introduce the demo and get everybody into taking a look at the demo of the actual solution?
Sure. So we follow a very structured 10-step process. And while this process is very structured and it's very flexible, because what life has taught us is that every organization is not going to be at the same level of data maturity. So we've broken down this implementation into 10 steps, and sometimes steps may go here and there, but traditionally they follow this methodology. Step one is all about enhancing the quality of your data. And we have seen data quality anywhere from a 2 out of a 10 to 8 out of 10, or 8 out of a 10. So we basically take all of the data and lay the foundation with enhancing the quality of the data. Your unit of measurements are not consistent, your descriptions are not consistent. Maybe the classification is in the older system, in an older version of the unspec, or you may not have gone to the next level of GMDN classification, so on and so forth. That's the first step. A second step is a very unique approach to creating the cost, quality, and outcome. So this originally came from the aircraft engines manufacturing as a best practice. So we actually take all of your utilization and all those data points that I talked about and create a customized bill of material for every procedure. And what that has is all of your average utilization, your brand preference, so on and so forth. Then we integrate the purchasing cost with the bill of material. What that does is now at a single line, we have at a case level on all the procedures. Then we integrate the reimbursement and so on and so forth. At the end of the day, when we go from step 1 to step 9, we basically have very specific recommendations for you to be able to say, here is how you can go about standardizing on your products and procedures. Here is where your opportunities are. You have 6 suppliers today, maybe consolidate them into 3 suppliers, blah, blah, blah. There can be any number of those recommendations. And what it does is, during this whole process, we integrate everybody. We integrate the supply chain, we integrate the clinicians and finance people, so on and so forth. Long and short of it is a very structured methodology, but flexible enough to take every organization's data maturity.
If you're okay, Ashok, I'd like to see if Diana can switch us over to the demo now.
So what my colleague Rishi is going to do is to show a sample demo of how the cost quality outcome works.
So let me start by saying that traditionally we take almost 2 hours to give this complete walkthrough of the application. But because of the time constraint, I'm going to touch upon only the salient features. The way this app is designed is that every hospital IDN acts as a parent, and then every hospital or facility becomes a child of the parent. This allows us to have the ability to roll up the cost and revenue and other numbers as well. You can either roll up or drill down these numbers across various dimensions like department, facility, organization, payer group, however you want. In the application, we have the filters. You can see the filters allow you to select a subset of data and perform an in-depth analysis across various criteria. The exhaustive set of filters enable you to drill down and have the view from a macro level to a micro level. So basically looking at an hospital ideal level to drilling it down at the facility, at the department, at procedure, at patient ID, case ID, even to the extent of the item, the part number being used at a case ID level. So it provides you an exhaustive feature and ability to slice and dice the data and bring those variances, understand what the variances are, what's causing those variances, and then be able to connect that to various metrics. The way we have designed this whole dashboard is that we always start from key performance indicators. These key performance indicators are the one which you measure to continuously watch, measure, and monitor. And these metrics, these key performance indicators can be customized based on every user. As Ashok said, that the skeleton is there and it can be customized depending upon the type of hospital, the size and the volume of the data we have, right? So then also the dashboard is able to fit in the requirement of different set of users. So either user is from a clinical department or from a value analysis or a supply chain or a finance. Each of them might have their own set of KPIs which they would want to track and monitor. And this solution is fully capable of supporting these customized requirements by each user group. So depending upon which user group you belong to, you can see corresponding menus and submenus, and through which you can drill down. Now, the way after, so right now, for example, if you are a physician, you have MyCQ and overall CQ options, and then MyCQ is for a physician to give a bird eye view around their own macro numbers, while in overall CQ you can compare multiple physicians on a par-to-par basis, right, across various factors. So the key factor, like key performance metric in here, we have the procedures, average revenue, average bill which we raise to insurance for this particular procedure, direct cost, indirect cost, various kind of margins as well, and then various physician related metrics as well. Then we have the outcome score. Here it's a 9.56 out of 10 for this physician. Now we put patient outcome as the fundamental and the central metric, and then build everything around it, because we cannot let our guard down on the patient outcomes. We can never allow patient outcome to drop for the sake of optimizing the cost. Otherwise, that will defeat the whole purpose of the analysis. So the way we perform the analysis is that for the cases where both patient demography and patient outcomes are same, we try to understand what the utilization is, where the variations are, how the utilization varies for the same procedure, how the case cost is constituted, and so on. So in these charts, you can see that we have various cost trend on a month-to-month basis, at a procedure level, then at a product level. So if we want to see for every product category how the trend consumption or the average usage has varied across month, not the usage only but also the average cost. So all that can be studied from here. And then we also have the option to see whether cost, not only the material cost but also the direct and indirect cost, and how they vary by facility, by payer, by department, and so on and so forth. So in this analysis, we did not find any correlation between the choice of an implant with either the patient outcome or the patient demography. So we came to a conclusion that if there is no correlation between that, then we can look for the saving opportunity, meaning we can bring down the cost without compromising on the patient outcome, because there is no correlation between the implant which is being used to the patient outcome. And then we can look for saving opportunities, and that means we can look for the manufacturer and brand preference for each physician, and see and compare various physicians and see why, who has affinity towards what, and can we bring down that to a benchmark manufacturer which is more cost effective or not. So I'll quickly go to overall CQO. In this, you can see we have taken four physicians, and all of them have the same outcome score. They have the same, almost same patient demography and all. So that means there is not that correlation there. Then, if I quickly jump to chart and show that, let's say, for here are all the four physicians, the various manufacturer which they are for whom they are consuming the products. And then if we look for a particular commodity, let's say femoral knee component, then we can see that physician 8 always uses Zimmer Biomet, and then physician 11 uses multiple of the manufacturers from a Johnson to Stryker, Arthrex, and all. And then physician 7 always uses a mix of Johnson & Johnson and Zimmer, and then physician 9 always for Johnson. So they have different preferences for the different products, for the same product from different manufacturers, and from there we can initiate some discussion around how to bring the benchmarking across the pricing, and then how to benchmark on a limited set of vendors, and then from there initiate the cost saving opportunities. So and also we have, as I said, multiple charts who help us understand various trends, have an ability to slice and dice, and then help us understand the trends. So the way, as Ashok explained, that the skeleton is there, the data pipe and skeleton, everything is already built. It's a ready-made platform. All we have to do is just bring in the data. So irrespective of which systems, which ERP systems are being used, which EMR, HR systems are being used, we have all the ready-made connectors to connect with all the data sets, pull in the data, and then all of these charts and analysis can be populated therein. And then once all the data is there, then the scalability of the platform takes over, and it provides you any number of benefits like insights like case per cost and all of that. So whether the cost is directly associated with the utilization of a particular product, or it's indirectly linked to it, all of that can be achieved. For example, this one of the chart I would like to show. In this chart, we saw that if the patient outcome for this procedure is same for all the physicians, the demography is same, but the revenue to charge ratio is different. For physician 9, a 15 cent is reimbursed for every dollar billed, while for physician 8, it's a 20 cent reimbursed for every dollar billed. So why the difference is there? So we go to these charts, and then from there we analyze that there is some correlation between the choice of manufacturer or the brand which has been used, or the quantity of the product which have been used, which has not been reimbursed, and that's why leading to a difference in revenue to charge ratio. So all of these insights as I said, are pre-built. It's just the data which needs to be bring in here, and then it can be formed. So that's it from my end. I can take any questions if anybody has.
Thank you, Rishi. There's two things that we still want to do in the next 15 minutes that we have with all of you. One is see if Ashok has some questions that will be whether or not you have questions or want additional information. There's a couple of questions, Ashok, coming through the chat right now about interfaces with other systems, and maybe you'd like to go in and address those. I'd love to give Dale a couple of minutes to take what Rishi just showed and talk about how this process and technology was able to drive the project that was completed at McLeod. Ashok, let me turn it over to you for a second if you want to address the questions about interfaces and then also sum up any points from the demo.
Yes, I think I already wrote it in the chat, Cheryl. We interface both. Yes, we interface with both Epic and Cerner, and any other system as long as that system has some kind of a handshake mechanism, which are called as APIs. And in the current situation, everybody has APIs.
Okay. Any questions, Ashok, that you want to ask of the participants right now? Should we go in and go ahead and do the McLeod outcomes piece of the discussion?
I think it's necessary for Dale to talk about it.
Okay.
We can, if the time permits, we'll ask the questions.
Perfect.
But I think it's necessary for Dale to those outcomes, those insights and outcomes are very insightful and they may be applicable to a larger audience.
And I think they're a great summary of the demo that Rishi just gave. So Diana, could you please switch our presentation mode back over to my presentation screen?
So while you're doing that, Cheryl, just one of the things that Rishi did a great job of is you can see that there is just a huge amount of information you can get to in this SupplyCopia in the work that's done and what's available as just standard things, the information and data. You can slice it and dice it all kinds of different ways. And like I said before, data is just data, and there's a lot of noise in that data, and I mean confusion. So old friend Vance Moore always said, if you're a vendor, there's money to be made in confusion. And so that's why there's a lot of it in healthcare. When it's used correctly, you build this meaningful story and you cut through all of that confusion and noise and you get people aligned on common goals. So what happened, and I don't want to fail to point out that what SupplyCopia did at McLeod was not only to do a project, but even more important, I think, is there's a framework now, a model that has been developed in the way that work was done that is very familiar to the surgeons and the physicians that are engaged. And because it has credibility to launch another project using that same methodology and that same those same tools. And so I think there's a lot to be seen there. What came about was, and I'm sure everybody's familiar with it, there was no correlation between patient outcomes and the choice of a brand of implant. There was no correlation about the demography. My patients are sicker than somebody else's patients, or I have this unique thing and only my brand of implant will work. And then there was a lot of confusion among the physicians, which SupplyCopia helped clear up about the difference in the cost. They had their source of truth that they believed to be correct in where they were getting their cost data, and I don't know where it came from, but what SupplyCopia was able to do was convince them that here's the truth, and then they bought into that. So they also were able to show them that all the work they did with Medicare, Medicaid related procedures were losing money. Third-party insurers, as it says on the screen, were profitable. But the charge to reimbursement ratio was about 21%. And it also brought out some things that we didn't expect, like the significant errors in scanning that led to products being missed in the billing process. And so it helped quantify that. Again, I think the importance of it is once you build a model like this that works, why not leverage it and move to the next step, to the next project? And I think that's really important, Cheryl.
Perfect. Thank you, Dale. Ashok, I'm going to turn it back to you. We were going to wrap up, and Dale touched on this, and you have as well, with the methodology that can advance people quickly through processes that will help them achieve savings. And then I know you had some questions that you wanted to tee up to the audience. Do you want me to pause on this slide or just go on to the question slide?
I would just like to say maybe two sentences is that this platform is been there, it's been tried and tested. We have, as the title of the webinar says, it's 6 months. 6 months, when we think about it, it's deploying it at an organizational level. But we always suggest that when you do something like this, you want to be able to tollgate it, you want to be able to implement it in such a way that at every stage you get the benefits of the platform, and also very hard numbers to take back to your CFO or clinical people or whoever. And the way we structure them is that first 100 days, you probably see the biggest bang for the bucks. And then as you bring more and more business lines onto the platform, then that number continues to increase. And we see that for all the money that our customers spend, we can easily think about a 15 or a 20 times return on investment on the platform and all of those things that. So we have a very measured way of building it, measured way of calculating the cost savings, and then each step kind of leads to the next one and keeps building on the success of the previous one.
And Dale and I were having a really interesting conversation right before this call. Dale, I'd love to call on you for just a moment about creating a path to sustainable savings, that it's not a one and done model. Can you talk about that? It was such an interesting part of the dialogue we had.
Yeah, I think I tried to touch on that a little bit just previously, but getting physicians into a comfort zone where they are familiar with someone and with the methodologies that are used to create the story, as I like to call it, so that once they have understood and agree with the work SupplyCopia did, we no longer had to spend the time on the front end of a project gaining that credibility all over again. It was there. And there was enough buy-in that you did this, we believe you, we don't think you're going to blow smoke up our back. So why not leverage that to go to the next project? It makes a lot of sense because you don't have to rebuild all the things you've already accomplished. And I think the value of that is tremendous. And I think I think the way that particularly Rishi just showed things is that the information is presented in such a clear way that it is easy to grasp it and to begin to put the pieces together to get to the heart of the story.
Thanks, Dale. I thought that was such an important point to reinforce. And Ashok, I'd like to turn it over to you to ask any questions of the audience that you have at this point.
Yeah, we would love to get some feedback on the methodology that we talked about and things like that. And the last one is, we believe in investing in the success of our customers, right? And we believe in investing, so we would love an opportunity to do a couple of pilots or anything in Q1 2023. And we suggest that the best way to do it would be to take a particular procedure that's been a pain for you, and then be able to run the whole pilot initiative with that and look at the success and the challenges that you would see there, and then be able to take it to the next level. Because as Dale was mentioning, that once the infrastructure is built, you built it, and then there is no reason to not to experiment with bringing on more business lines online. We asked this question in the beginning as well. There are certain known challenges like the data, the analysis, so on and so forth. Then obviously bringing all of these things, how can we help you in overcoming some of these challenges? And would there be an interest to sign up to a proof of concept, and this proof of concept is actually our investment. So it's not that they need to pay anything for it, but where we would want is their involvement from the concept perspective, from the buying perspective, and bringing the data to the table, and then we can let the tool do its magic.
I just want to ask if there are any comments on the demo, any questions for the team. BJ McCluskey from McLeod did have to jump off for a conflict that he had, but he offered that if anyone was interested in knowing any more details about the program that they ran at McLeod, he'd be happy to hear from you, and either Dale or Ashok or I could forward a message along to BJ. If you don't have his email, we're happy to facilitate that. Any questions or comments? Alan, you went off of mute. Were you going to make a comment?
Yeah, Cheryl, thank you. So for me, thank you. Always very interested in how we use technology and leverage it in supply chain. I think two comments in general is one is that I always see tools like this that it really depends on the culture of your organization, right, and how supply chain is looked at. And if you've ever heard Dr. Randy Bradley speak from University of Tennessee, he always says, is supply chain a commodity or a strategic partner in your organization? And excuse me, but that moves me because if you're looked on as a commodity in your organization, you're not going to get a tool like this past your senior executive team. And I'm a part of the executive team here, but I don't sit on that C level. And we actually have a tool like this, and would be glad to compare notes sometimes if you would like to, without breaching any of the confidentiality that we have with our current vendor. You have very similar technology. I think for me, if I didn't have anything, the ultimate elephant that's always in the room is, okay, so tell me about the cost. And oh, by the way, we just missed the budgeting window. Like we're on a, every October, we got to have our budget in, and if I don't have budget, that means that I can't do anything for a year. So no matter what we demo, no matter what we do, no matter what proof of concept, I'm probably not going to get an opportunity to move forward with looking at a new technology. Excuse me. And I always say that, if it cures cancer or you'll save us $1 million, my boss, the CFO, will go, Alan, let's have a conversation about that. But to get to that point right now in the culture that we're in, where it's deficit all year long. I mean, we just turned a profit the last 2 months, and we're not going to break even for the year end. And so the losses for our organization in particular are pretty enormous right now. And so I think that's the other piece, just realistic feedback, Cheryl, is that if we'd have had this conversation a year ago, I would have probably been ponied up saying, hey, yeah, I'm your guy. Let's take a look at this and let's see what we can do to further that along. Like I said, I'm always willing to give feedback openly and honestly about this, and that from our days before at GHX. I mean, it's like whatever we can do to help supply chain and help healthcare providers overall, I'm willing to do. But for me, that's the feedback I have to offer today, just from a realistic perspective.
Absolutely. And I appreciate you making those comments. I think the reality of everyone's world is that there's always a budget cycle, and there are points in the year where you're not going to be able to change anything in midstream, and it's something that you think about for the future. I think Ashok and his team might be really interested in hearing more from you about if there's any net gain that their solution could provide compared to the vendor that you're using right now. I think they're always looking for ways to make sure that they're doing the most to solve problems that organizations have. So love the opportunity to follow up there.
I'd be glad to do that. I always say that if somebody can take the cradle to grave solution from product request or product evaluation all the way to disposition, you've hit the home run. Because what happens is we use disparate tools. It's like, oh, I got this for product introduction. Oh, I got this for analysis. Oh, I've got this for something else. And then, oh, by the way, I use Workday to make it all go. And so it's just crazy. And I think would love to have that conversation. So if you want to put me in contact
Perfect.
Afterwards, we'd be glad to work with the team and
troubleshoot
some bit.
Cheryl, I would like to make one comment to Alan, if you will permit me. I know that everybody is scared. Alan, I 100% agree with you. I would go to the additional step of saying that it's not that supply chain is strategic or not. Supply chain is the only lever that you have left in the organization anymore. There is a reason why Tim Cook became the CEO of Apple and not Johnny Ive. And I think the reason why supply chain is not yet in the boardroom is because we have done ourselves a disservice by not being aggressive enough.
Mhm.
And being able to take this and say, um, supply chain can own the responsibility of showing an organization how it can work in the future. I think we have done a bad job of it.
Yeah.
And I go to the another step and saying that it should not just in the decision making. If your second biggest spend is in the supply chain area, and that's the only area that you can control, then shouldn't that head of supply chain be actually a board member, not even in the executive management, but go one step further, especially taking into consideration what happened during the pandemic.
Agree.
I am going to go ahead and wrap us up. Ashok, in the chat, there's been a couple of questions that have come through. Alan, we'll follow up with you directly. Ashok, I know from Diana, we'll receive the notes in the chat so that we can do that additional follow-up. And folks that are still on the phone, I'd like to invite you at any time to reach out to us, either by visiting the SupplyCopia website. I've got contact information for Ashok. Diana can put you in touch with any of us. Happy to follow up and be in touch. And thank you so much for taking the time today from your schedules to join us. It was really good to see everybody. Good to see familiar faces and reconnect with folks out there. And we so appreciate your time and your participation and your attention and thoughtfulness throughout this process. Just let us know if there's any other questions that you have, and then we'll do some direct follow-up with some of the individuals who have suggested it and requested other information. So thank you. And thanks to the SupplyCopia team and to the HCP team for teeing this up today. Thanks, everybody.
Great. Thanks, everyone. Happy holidays.
Thanks, everyone. Thank you.
Thank you, you too.
Thanks,
Thank you.
everybody.
Take care.
Bye.